Welcome to another exciting edition of the Trading Bell. This week, we focus on the Uhuru Kenyatta legacy. We detail some of the key sectors under President Kenyatta's administration, and one among them has been affordable healthcare. And through this, the government has been pushing an agenda to provide universal health coverage into various pockets of the country. How did this perform under the Kenyatta administration? And what were some of the hits and misses? We'll be taking stock through the eyes of Dr. Peter Kamunyo, who is the Chief Executive Officer of the National Hospital Insurance Fund, NHIF, and we'll be also taking stock of how the fund has performed. Thank you so much, Daktari, for making time for us. And just a few days to the elections, a lot of heat when you look at the political scene. But aside from the noise, we've also seen the president launching quite a number of projects, from the expressway to the train stations in Nakuru, and among other projects, including hospitals, which were built under the level 5 hospitals. But for you, what would you say was the one thing that, as we kick off this conversation, really stood out for you, especially when it comes to progress as a country?
Thank you very much, Abby, for having me on the show. And I think from where I sit, the first big thing actually is even a correction of the introduction, where we moved from National Hospital Insurance Fund to now what we are as National Health Insurance Fund.
Yes.
And by amendment of the Act, the NHIF Bill 2022, NHIF Act 2022, that was a huge, huge milestone in terms of getting us closer to ensuring that every Kenyan has access to the quality healthcare that they need without suffering financial hardship, which is one of His Excellency the President's key Big Four agenda. So right now, you can see from the progress that there are more people who have access to care than before. We have more people who have access to quality care because of availability of facilities in the hospitals. I will start off by stating that, to get to universal health coverage, it simply means that you're able to access the care that you need without getting out of pocket, without becoming poor. It doesn't mean that it is free. It doesn't mean that everybody is getting exactly the same. But it means that where you are, you're able to access without getting impoverished. And we know that 1 million Kenyans actually every year become impoverished due to catastrophic health expenditure. And if you look at the progression of NHIF, if you look at the progression of the legacy of His Excellency the President, the main focus has been to ensure that more people are covered and more people are able to access that quality care. And you can see that from the progression straight from 2013, because the key elements of getting to UHC are actually 3, and they're very simple. Number 1 is economic empowerment. And by economic empowerment means that even those people who cannot afford are able to be provided for access. And you can see a very clear demonstration from 2014, just 1 year into His Excellency starting the term, with the sponsorship of, through Health Insurance Subsidy Program, that's HISP for orphaned and vulnerable children. There was also HISP, Health Insurance Subsidy Program, for the elderly and severely disabled. And this kicked off that element of, first of all, empowering those who cannot afford. Another key element of is ensuring that everybody is on board. With the new NHIF Act 2022, one of the key changes that were made is to ensure that every Kenyan above the age of 18 is a member. So this ensures inclusivity. In addition to that, the government is obligated to identify and support the indigents who cannot afford basic necessities of life, including healthcare. Now, the third element of getting to UHC is, what are they getting? It is the benefit structure. And you have seen, actually, if you look at now the history and the trajectory of NHIF, the big change that happened was in 2015. That was 2 years into His Excellency's term. That is when we introduced several packages, notably outpatient, notably dialysis or renal care, and also mental health, taking care of those folks who also have mental issues. And this was driven by the actual need of the people at that point, because these were conditions that were making Kenyans poor, making Kenyans who cannot afford not be able to access care. And from there it has been a progression. In 2016 we introduced the surgical packages. We introduced the cancer package, which right now is saving so many lives. And then we also introduced that same period, 2014, Linda Mama. That's when Linda Mama was transitioned into NHIF. And by that, you can see that at the moment has led to over 60% of women in this country having access to supervised delivery. So those three elements of economic empowerment, ensuring everybody is on board, and ensuring that there's a package that speaks to the needs of the people has been a major, major, major trajectory in terms of growth and acceleration in this journey towards UHC. Because UHC, as many people say, or you can hear, oh, we are going to start UHC. No, you cannot just start UHC. UHC is a journey that we began from the time of inception of NHIF.
Would you say you are happy with the progress under UHC, or is there still more ground to cover?
Like I said, it is a journey, and we are not yet there. But I can say that with the efforts being done at the ministry, at government, and the reforms at NHIF, we are way on course. And if you look at even the pilots that have been done to try and get us, initially in 2018, we had the pilot in the 4 counties, whereby it was phase 1 and phase 2 of UHC, whereby it was an input-based model. And what did we mean by that? It meant that you equip the hospitals, and you've seen the success that we've had with the managed equipment scheme. It meant that we get human resources. It meant that we get commodities in the hospital. And you saw with those, KEMSA actually came through, and the hospitals and the counties that we had the pilot were equipped. This is what we call input financing model. So now the registered members could be able to go to those hospitals and access. But now we are now in phase 3 and 4, which is the escalation, is actually scale up for UHC. And the model that we're using for phase 3 and phase 4 is what we call output-based model, which is insurance model, or in other words, risk transfer. Because in the initial phases, it was government inputting and ensuring facilities are available. But right now is a risk-based model or insurance model, whereby we have everybody on board contributing something small. Right now it's 17 shillings a day equivalent, or 500 shillings a month. And you're able to get this whole suite of benefits. And then when we have everybody on board, so those who are sick are able to be supported by those ones who are not sick. And if anyone gets sick within that pool, they're able to draw from it. But the other big thing about that is that even as we go to that output-based model or insurance model, is that they have somewhere to go and they actually get the services. And that is why you've seen with His Excellency actually opening up a lot of facilities. You saw the PET scan at Kenyatta University and Teaching Referral Hospital, KUTRRH. And the PET scan, that was one of the leading reasons for people leaving this country of ours to go out to seek. You've seen the cath labs that have been opened, also at KUTRRH, at Coast General Hospital as well. And this has led to us being able to save lives of many more Kenyans by availability of these facilities. And guess what? NHIF reimburses fully for these services for our members.
All right, and allow us to shift gears a bit, Daktari. I'd like to get your assessment. When you look at the President Kenyatta administration, there's been a deliberate effort towards increasing budgetary allocations to the Big Four and the Big Four agenda.
Yes.
One of them, of course, being healthcare. Talk to us about this. Have we seen the size of the fund also growing, the membership base, as you have been the helm of the organization?
Yes. Actually, as a fund, we've had a phenomenal growth since 2013. In 2013, the membership stood at 3.8 million households. That is registered in the system. As at end of this last financial year that ended the 30th of June 2022, the registered members in the system were more than 15 million. So we're talking about almost 5 times growth over that period. We're talking about from collections of about just slightly over below 5 billion to now collections of about 80 billion. But that's not all. 90% of what we are collecting now is actually going back to pay for claims. So we can see the growth has been actually phenomenal. Another key point to note is that because even with the 15.1 million members that we have right now, we have members who are statutory contributors, employed folks like you and I. Mm-hmm. Then we have voluntary contributors. Those are the ones who in the informal sector. And then we have those who are sponsored. Now, from around 2013, there were only about maybe 30,000 sponsored families. As at end of last financial year, we have more than 1.3 million sponsored households. Meaning, actually, we have more sponsored households than the active members of the voluntary contributors. So this is a phenomenal growth in terms of our journey towards UHC, where we are going to ensure everybody is covered.
And as you celebrate these milestones, Pana MD, of course, running the fund of that size attracts a lot of governance questions. And the health sector has not been spared of incidences where we've had cases of fraud. Perhaps walk us through in regards to good governance. We've already seen quite a number of issues coming up across the sector, and one of them, of course, being the COVID billionaires. Not forgetting one of the entities under the health realm, KEMSA, yes, coming in for scrutiny. And for your end, what have been some of the challenges that have really dominated your stay in office, as well as growing the fund and making it to be more of a success rather than causing tears to families?
Yeah. No, that's a great question and a great concern, because even from where we sit, insurance or social insurance, it's a business of trust. Yeah, we trust that the money that you will give, you'll contribute, we will keep it and use it for the services that we have contracted our hospitals, and the hospitals trust that we will pay them for the services. So insurance in general is a business of trust. And transparency and accountability is very key. In fact, as some of the key principles that drive me and what we came in to do, there were about 5 things. And one of them was to listen. Because to be able to, govern well, to have good governance, to be able to know what is going on, is to listen. To listen to the pain points, to listen to suggestions, etc. The second one is the people that you have. So this we're talking about the staff, so that we ensure that you create an environment whereby you're not just talking about head count, you're talking about heart count. Staff who are committed to delivering. In fact, that is one of the key questions that we used to ask. When you come to the office, what are you coming to do? What are you hoping to see? Are you coming because you just want to earn a salary? Or are you coming because you want to save a patient's life? Then another key one, and is related to the question that you've raised, is restoring trust. Indeed, trust has been broken in very many ways. And you know that in the business that we're in, there are a lot of funds that are contributed for something that might or might not happen. So ensuring that we are able to secure also those funds. Actually, in our act, one of our mandates is protecting the fund. So ensuring that we are in a position of trust and transparency, because it's not just trust. The only way people trust is because you're transparent and they can see. Then the other key point was to save money or contain costs. NHIF collects contributions, and those contributions are finite. So that means whatever we collect, there is a ceiling to it. We do not receive money from the exchequer. We use the contributions of our members to be able to pay for claims. So saving money is key to ensure that we maintain. And this is part of the good governance. Then finally is the adding value, so that we're able to treat you well, you're able to enjoy your experience. I know we've had some challenges in the last couple of days regarding like pre-authorizations, but that was because of the transition into the new contracts, which are again embedded in the system. So it was, what you can say, a slightly good problem to have, because what we ensure is that there is no subjectivity in terms of the way we authorize for reimbursements, because all this is embedded in the system. And these are the elements that ensure that we have good governance, the elements that ensure that all our stakeholders actually trust. And I think even in the new act, one of the key things is that we need to make also our books public, so that we stand the scrutiny. Mm-hmm. Thank you.
And as we finish off, Dr. of course, we've covered quite a lot in terms of some of the hits. And I was just keen on just picking your mind on some of the misses that you feel will characterize the next several years as we transition to the next administration.
Right.
What would really be top on the agenda for you, especially when it comes to correct some of the key issues that you've talked about?
Right.
The issue of pre-authorizations, the issues of delayed payments to hospitals.
Correct.
Issues touching on actually bordering on collusion, where hospitals colluding with patients. How do we streamline all this?
Yeah. I think if I were to put like the top 3 areas that would need major improvement, number 1 is the hospitals, because the hospitals, the healthcare providers, are the instrument that we use to deliver on our promise. So number 1 for me would be availability of services at all our healthcare providers. Like I mentioned, we have standardized our reimbursements across all our types of providers. So this is the private, faith-based, and public hospitals. So with that reimbursement standardized across, if the services are available at all these facilities, and especially the public, it would go a long way in reducing that, because it means that there would be no pressure of going to areas whereby there can be collusion, etc. And people will be competing on service and quality medical outcomes. So for me, that is number 1, that we work together with the counties, we work together with our private providers to ensure that the services we have promised our people are consistently available. And one of the key areas we've done on that to promote that is engaging with the Council of Governors, that they amend the acts in the counties to ensure that the funds that we reimburse the hospitals are actually ring-fenced and used for development of those facilities, to ensure that commodities are available. So that is number 1. The other one is to ensure that we also enhance our digitization, because there is the only way we can be able to, in real time, be able to detect or deter is through having a robust digital system. So even now we are working towards a new system eventually that can be able and is more advanced to be able to have all these things digitized. So that will be very key, and that can be an area that would also help to lock the taps. And that involves also the identification. It involves also getting reports in real time, so you can be able to have evidence-based interventions, etc. So that is very key. Then the other one also regarding also our staff. So training, improved and continuous training, and ensure that the systems are able to speak to those needs. And one of the key, like those pre-authorizations and case management, we've actually created now a division in our new structure that will be able to follow up. So my looking forward is operationalizing these new reforms to be able to intervene. And then finally, and this is also quite big, is that to have UHC, everyone must be on board. So ensuring that all our indigents are actually covered. So even as we transition in the government, you know that the government of His Excellency, the President Uhuru, right now are sponsoring 1 million households. 1 million households. And we know that we have about 5.1 million households that are indigent. So there's a balance of about 4 billion.
And of course, all this comes at a time where Kenyans are really keen about health. And I just want to get your parting shot, really, especially on this controversial issue where many haven't understood this decision that you increase the surgical procedures, and this might see you raising some of the costs by about 12%.
That's an interesting question. And, interestingly, the last time that we increased the contributions was in 2015. And that's the time when we introduced also the new packages within this period. And we have continued to increase the packages and the offerings that we have. Yet to date, this is almost 8 years later, we have not increased the contributions even by 1 shilling. And we have been using the resources that we're getting from the contributions of our members to be able to pay. And by increasing efficiency, this has been fitting in. So in this contract cycle with the harmonized benefit structure, we have increased the scope. We discussed and negotiated with providers for months to arrive at these negotiated rates. And the main purpose of that is what we landed with the 2 contracts, where we have the comprehensive contracts where any Kenyan who is a member will walk in and walk out without paying a single shilling. We standardized that reimbursement across both public, private, and faith-based organizations. So that was key. So we have not yet increased our contributions. We are having our actuaries look at the numbers, and we'll need to see what the effect will be of having everybody on board. We'll have to wait and see the effect of the increased packages. But we think that the change, even at the point where the actuaries would advise, would not be significant or a train smash. So we are urging, and as a parting shot, to make this work without increasing the burden on our pockets in terms of contributions, is to make sure that everybody is onboarded. To make sure that all those people who pay only when they have a need are consistently on board. And that we might be able to contain and not maybe even increase the contributions if we have everybody on board. So there's no need of waiting until when you're sick and you're running to hospital and making many calls, oh, can I be active? Because that is adverse selection, and that cannot happen. And that is what ails NHIF. And that's what has led to, big loss ratios on certain schemes because of waiting until somebody's literally at the doorstep of the hospital to start paying contributions. So my key message is to ensure that we have everybody contributing. 17 shillings a day per family will save you millions of shillings. And secondly, that all the indigents to be identified and supported. And thereby we have universal health coverage. And we'll have achieved one of His Excellency's Big Four agenda, which is access to healthcare for all in Kenya by the end of this year, 2022. Many
thanks, Dr. Peter Kamunyo, for speaking to us.
Thank you very much, Abi.
Well, we continue with our President Kenyatta Legacy series as we look at some of the key aspects that have been achieved within his term, and quite a lot coming out from the health sector. And of course, we continue to keep our eyes focused on how will things pan out come the transition. Well, that has been our show for today, and I've been your host, Abi Agina. Until next time, keep safe and see you later. I leave you now with the day's markets.